Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on insomnia treatment options. This video is going to be an overview, an insight into what I think of when patients come to me complaining of insomnia, and I have to figure out how I'm going to help them get to sleep pharmacologically. So I'm just going to kind of do a brief overview of the different classes and the different agents that come to mind, the armamentarium, so to speak, that is available and that clinicians like myself, psychiatrists in particular, tend to reach for. The selection of medication, it's always a recommendation. There are always options. Your prescriber should always give you options, but selecting the agent is very complicated. I can't give you a simple algorithm that's going to tell you which agent to choose. You have to really consider the entire case. So not all of the options that I'm going to discuss today are necessarily viable options for all patients in all instances. And at any rate, they're never equal because it depends on so many variables, from demographics, the patient's age and gender, to the target symptoms that we're treating. Are we dealing with depression? Are we dealing with high anxiety? Is it a substance use disorder? We have to consider side effects that would be poorly tolerated or that would be deal breakers. I have to look at the current medication list to consider any potential drug-drug interactions, including side effects that could be additive or synergistic, and other considerations, such as how the patient may have responded to a similar agent in the past, including over-the-counter remedies. For example, if a person responded poorly to over-the-counter antihistamines, then selecting a prescription hypnotic agent that induces somnolence primarily by blocking H1 receptors might not be the best choice, histamine type 1 receptors. Or, since that often stimulates the appetite in patients who refuse to gain weight, that might also be a deciding factor. It could be a deal breaker, or if patients are already obese or they have diabetes, or etc. So all of that has to be considered. We also have to consider the diagnosis, what we're treating, because there are some diagnoses that determine what we can and can't use. And in particular, I'm talking about substance use disorders. Many individuals with alcohol use disorder can't safely and responsibly take habit-forming soporifics because it's too hard for them to control the dosage. They fall into patterns of misuse, even if they're trying to be responsible and they're not wanting to take the medication recreationally. So there are a lot of considerations. However, all things being equal, I'm going to proceed as though all of those factors weren't in play, because I'm just going to tell you about all the classes and I'm not really going to tell you which one I would choose. It just depends on the patient. What is the armamentarium of sedating agents that are available to us that might be useful? Here are the main agents that usually come to mind for me. We're talking about treating initial insomnia. There are three types of insomnia. Initial, which is trouble initiating sleep, trouble falling asleep. Sleep latency, which is the time between the time that you lay down and hit the pillow and the time that you actually fall asleep. That's called sleep latency. So when that's way too long, hours and hours, and you're tossing and turning, you have initial insomnia. You can also have middle insomnia, where once you get to sleep, whether you had trouble or not, you then wake up a lot in the middle of the night. That tends to happen as a person gets older, but it can also be a symptom of an anxiety syndrome, and it can also be a side effect of antidepressant medication. So a lot of times patients come to me and fully 50% are already having some trouble sleeping, whether it's a separate deal or whether it's part of whatever syndrome we're going to treat, especially anxiety. And so they may already be having it. If they don't have it, then I might induce it with the medication that I'm going to give, antidepressants, stimulants. A lot of medications cause middle insomnia, where a patient will wake up a lot. Usually patients roll over and they get back to sleep with no problem, but when they wake up in the wee hours of the night, 3, 4 o'clock in the morning and they can't get back to sleep and they are awake until it's time to wake up and then they feel exhausted. That's called terminal insomnia. So initial, middle, and terminal insomnia is one classification system. Another classification system is to say insomnia can be primary or secondary. Primary stands alone and it's not secondary to some other condition. If it's secondary to a major depression or it could be a side effect of a medication, etc., etc. So it can be primary or secondary. The DSM-5, the Diagnostic and Statistical Manual, does have a separate diagnosis called insomnia disorder, defined as a predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms. Number 1, difficulty initiating sleep, initial insomnia. In children, this might manifest as difficulty initiating sleep without caregiver intervention. So someone has to be at the bedside every night. 2, difficulty maintaining sleep, characterized by frequent awakenings or problems returning to sleep after awakenings, i.e. middle insomnia. In children, this might manifest as difficulty returning to sleep, again, without the caretaker coming in and reading them another bedtime story. And number 3, early morning awakening with inability to return to sleep. So the kinds of insomnia that I just described. The sleep disturbance has to cause clinically significant distress. The person has to be subjectively distressed, or there has to be impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. There's also a frequency criterion. It has to occur at least 3 nights per week or more, and the disturbance is present for at least 3 months. So it has to be ongoing. The sleep difficulty occurs despite adequate opportunity for sleep. So it's not that the person is being prevented in some way. And the insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder, such as narcolepsy or one of the parasomnias. It's also not attributable to the physiologic effects of a substance, either a drug of abuse or a medication. And coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. So you gotta rule out all these other things that the insomnia could be due to before you call it primary insomnia, insomnia disorder. And so I don't think I've ever, well, no, that's not true. I have diagnosed primary insomnia when patients come to me with that chief complaint. That's all they're complaining about. A lot of times you find that there are other things going on, even if they're secondary to the insomnia. If the insomnia is not secondary to something else, they could have anxiety or they could be having other problems because they're not sleeping. So I have diagnosed primary insomnia, but it's uncommon that I will diagnose insomnia disorder, quote unquote, because usually, even if the insomnia is not necessarily secondary to a major mood disturbance, for example, it is often comorbid with another syndrome, and I just note the presence of insomnia, and I consider it part of the global syndrome, and I don't give it a separate diagnosis. So I have diagnosed it when it's just insomnia. There are also specifiers. You have to specify whether the insomnia is comorbid with a mental disorder, including substance use disorders, or whether there's a medical condition that's comorbid or another sleep disorder. And then you also specify if the condition is episodic, meaning symptoms last at least 1 month but less than 3 months, or persistent, where symptoms last 3 months or longer, or recurrent, where you have 2 or more episodes within the space of 1 year. So these are all these different ways of classifying it. Acute and short-term insomnia, where the symptoms last less than 3 months, but they otherwise meet all of the other criteria with regard to frequency, intensity, distress, and or impairment, should be coded as a, quote, other specified insomnia disorder, according to the DSM. You know, the DSM, it is a research tool. In the real world, we don't need all of this nomenclature. Insomnia is insomnia, and you want to figure out what's causing it. and what it's a part of, and the treatments that I'm going to talk about. It doesn't matter how we classify it and specify it and all that. This is mainly for research purposes. The DSM goes way into detail that I can guarantee you clinicians are not spending all day. Regardless of all of the above, what we need is a central nervous system depressant, a CNS depressant. So melatonin is a hormone that was discovered in 1958. It's secreted in the brain from the pineal gland during the night, and it plays a crucial role in regulating the sleep-wake cycle, which is also known as the circadian rhythm. How does the brain know to secrete melatonin? In low-level light conditions, as gauged by the optic nerve extending from the retina to the rest of the brain. The eyeball is part of the brain, really. And it shines on the suprachiasmatic nucleus of the hypothalamus. When the eyes are exposed to sunlight, the pineal gland's melatonin production is suppressed. So you take the brake off when there's no more light stimulating that nucleus in the hypothalamus, and so you get secretion of this hormone. This is why blue light is such bad sleep hygiene. The red spectrum light is a lower intensity, lower frequency, and lower energy state than the blue end of the spectrum, the ultraviolet end. And so you should filter out the blue light from your devices. If you're looking at screens at night, if you're reading your Kindle or you're looking at your phone and it's close to bedtime, you should filter out blue light. All light is going to stimulate that nucleus and is going to cue you to be awake. And so it can really mess up your circadian rhythm if it's nighttime and you've got all these lights on and you're staring at a bunch of light, but blue light especially. There are 2 melatonin receptors, and over-the-counter melatonin is the full agonist at both. It attaches to both and stimulates both of them. It's over-the-counter in Canada and the United States, but interestingly in the UK, you can only get melatonin by prescription. Here, the FDA treats melatonin as a dietary supplement, and as such, it's not approved for any medical uses. There are synthetic melatonin receptor agonists that have been developed and marketed recently, like Ramelteon. I've never prescribed them, so I can't tell you if they work, but I will tell you I haven't gotten great reviews from the patients that I've treated that have been prescribed those new agents. As far as melatonin itself, does it work? The short answer is no. There's no good evidence that melatonin helps treat insomnia, and its attempted use for this purpose is recommended against by the American Academy of Sleep Medicine. There are anecdotal reports. I've had patients tell me that they take it and that they do well with it, but in my opinion, that's probably a placebo effect, which is still an effect. An effect is an effect, and melatonin is very safe and well tolerated. It's best for circadian desynchrony. So in theory, it would be good for jet lag or shift work disorder when you're off your cycle. But really, if you're going to take it, you have to pair it with good sleep hygiene. So you got to be trying to sleep in a dark room with maybe an eye mask if there's light, and again, no blue light before bed. And if you are going to take it, 2 or 3 milligrams, there's no evidence that taking any more than that is useful. They've compared low doses to higher doses, and it's sold in 5 milligrams and 10 milligrams, but that's more than what you need. So even though it is safe, people can have different side effects from it, headaches and nausea and malaise, just sort of non-specific things. It's generally well tolerated, but take the lowest dose that you can. I never recommend it, honestly. I never recommend it. If a patient is off on their circadian rhythm, if they're going to bed at a different hour every night and they're waking up at a different time every day, I tell them the first thing that they need to do is get into a rhythm. It doesn't matter if they're night owls, that's fine, then they need to sleep in. They need to get their hours, and they need to get them all at the same time, and they need to be consistent. That's called good sleep hygiene, and I've got videos on this. By the way, I've got videos on most of what I'm going to talk about today, most of the agents that I'm going to talk about today. So this Ramelteon is the first in a new class of sleep agents that selectively binds to the melatonin receptors in the suprachiasmatic nucleus, and it's used For insomnia, particularly delayed sleep onset, it's not been shown to produce dependence, and it has no potential for abuse, so it's safe, but I just don't know how effective it is. Well, I'll tell you, there are way more effective medications at putting you to sleep. The problem is that the ones that are the most effective tend to be habit forming, and even if you're not abusing them, you're going to develop tolerance. And so if you don't use them judiciously, then they stop working after a while. And that's the biggest problem I have, is that patients will do fine with what I give them, but then if I don't do it right and they don't take it right, then you can get tolerance and you can lose efficacy. Please check out my How to Make Your Sleeping Pill Keep Working video for more on that. Traditional sleeping pills, initially we had sedatives like the barbiturates, phenobarbital and such. They're not prescribed anymore for insomnia because they're dangerous in overdose. You can actually die from central asphyxiation. You can completely suppress a person's respiration, put them in a coma, and kill them with an overdose of barbiturates. Nowadays, barbiturates are reserved for the treatment of seizure disorders. A lot of times you'll see that they're being prescribed with other anticonvulsant agents for seizure disorders, not for sleep. Some of the older agents, I'm not going to talk about, chloral hydrate and such, we really don't prescribe those much anymore. Benzodiazepines, as far as traditional sleep medications, are by far the most commonly prescribed, and certainly they're the ones that I will use and often combine with other medications if there's already some tolerance. If the patient is not benzodiazepine naive, if they're veterans, or they're already taking benzos, or they're taking benzos throughout the day for anxiety, then they're not necessarily going to work all by themselves. And so sometimes you have to do these advanced strategies. But benzodiazepines are much safer than barbiturates. They're used also for anxiety, as I said, and also in seizure disorders, as well as muscle spasms. They're prescribed for restless legs, agitation, catatonia in special psychiatric populations. Please see my recent 2-part video on the benzos if you want to get an overview and more information there. The benzodiazepines that are approved for sleep are short-acting, and they include Halcion, Triazolam, and Restoril, Temazepam. And I have a video on Temazepam, and I also talk about Halcion. They're short-acting agents, and the problem is that once you develop tolerance, then you get a lot of middle insomnia. So patients get off to sleep okay, even after they've been taking the medication for a while, but they don't stay asleep. And that has a lot to do with the short half-life. So when you develop some tolerance, that plus the short half-life, and you end up waking up a lot. Same for Ambien. It's got a real short half-life, so once you've been on it for a while and you develop tolerance, you go to sleep okay, but then you wake up. It just doesn't last. But Ambien CR, controlled release, is one option. Ambien is not a benzodiazepine, but it has the exact same mechanism of action. So the difference is that it binds to a specific isomer of the GABA receptor. Ambien and Sonata and Lunesta, they're a little bit more specific, and there's an idea that maybe there's less tolerance, less dependence with them. I still see rebound insomnia when you stop these short-acting agents. And so when you take them just for a short period of time, and they're not approved for long-term use, 7 to 10 days is what the FDA approves. We often will use them off-label for a longer period of time, but whenever you do stop, you tend to get that rebound insomnia where now they can't get to sleep, and it's almost worse than it was before they started taking it. I get good results with lorazepam, which is not specifically approved for sleep, but it has a medium half-life, 15 to 20 hours, and the right dose, it lasts all night with no grogginess in the morning if you dose it right. It just depends on the patient. Again, the problem with benzodiazepines is tolerance, and they do have an abuse potential, and there is physical withdrawal when you stop taking them. And if you have been abusing them, you're on high doses, or if you've been combining them with alcohol, you could have withdrawal seizures, and in the worst case scenario, status epilepticus and death. So withdrawal from benzodiazepines could be life-threatening. It's not common that a person dies from benzodiazepine withdrawal, but you can. As I said, Ambien controlled release, they have the same mechanism of action, but the CR is probably a little bit better to keep people asleep. Otherwise, people wake up and they tend to engage in these complex sleep behaviors. I have a video on Ambien. Please check that out. There's also a form of zolpidem. Zolpidem is Ambien and Ambien CR. There's a low-dose zolpidem called Intermezzo, and it is a sublingual preparation that you take in the middle of the night if you wake up for that middle insomnia. You have to have at least 4 hours of sleep time remaining. And if you do that, you can put it under your tongue, it dissolves and you absorb it fairly quickly, and then you get back to sleep. But it's just fast-acting zolpidem at a lower dose. Sonata is Melatonin, and Lunesta is ezopiclone, and they're very similar. Sonata is very weak. It's not prescribed very much, but it also was touted as a medication that you could take in the middle of the night, because they actually did studies where they would give it to people and then they would wake them up, and there was no clinically significant impairment. So I used to recommend it to patients for middle insomnia. I don't really use it much anymore. It's mild. And then you have Lunesta, which the drawback there is that it has this terrible taste. Not only does it leave a bad taste in your mouth, but then when you're tasting other things, if you're on Lunesta, certain foods just taste weird. And that's a deal breaker for me, for sure. For me personally. Trazodone. Trazodone is a potent serotonin 2A antagonist. It's also a mild selective serotonin reuptake inhibitor. It has a mild serotonin reuptake inhibition properties. It is approved by the FDA as an antidepressant. It's not habit forming, and it's got several advantages. It's got a wide dosing range, starting at 50 milligrams and going up to 150 milligrams for sleep. Although you can actually take the dose as high as 600 milligrams. And when you're treating depression, we don't use trazodone in monotherapy anymore to treat depression, but when we did, we would give doses up to 600 milligrams. But you want to start low, because I had a patient that just very recently I prescribed trazodone, and I wrote 50 to 150, and she took the 150 right away and woke up and was ataxic, meaning she was stumbling around and slurring her speech and completely groggy, because you have to develop some tolerance to those side effects. It's not habit forming in the way that benzodiazepines are, and there's no withdrawal, but you got to get used to the medication, so you don't start at 150. But carryover sedation is certainly possible, especially at the beginning. Other side effects, it can cause orthostatic hypotension, orthostasis, where if you stand up too quickly, you get lightheaded and you can actually fall. So you want to move slowly whenever you're lying down or sitting down and you stand up. You don't want to do that too quickly, and you want to stay hydrated while you're taking trazodone. Orthostasis is pretty common. Another side effect is nasal congestion. I took trazodone at one time, and I mean, it was severe. It was so bad I couldn't sleep. I had to mouth breathe, and I actually could not sleep because I had such congestion. That's fairly common. There's another curious side effect with trazodone where you see after images. It's called palinopsia, and it has to do with that 2A receptor, that serotonin 2A receptor, which is also a receptor that is involved when you take mushrooms, psilocybin, and other hallucinogens. So it's really an illusion is what it is. It's illusory. It's not a hallucination per se. It's called palinopsia. Palin meaning again, opsia, seeing. Rarely you see priapism with trazodone, where men might get an erection that lasts more than 4 hours and that doesn't go away. It can be painful, and it can actually be a medical emergency. So if that starts to happen, then a person should stop taking the trazodone for sure, because the treatment for that is going to the emergency room for an injection of norepinephrine, a potent vasoconstrictor in the corpus cavernosum of the penis. And that doesn't sound pleasant. Mirtazepine is a great option, except for the weight gain. It's a great antidepressant. It's less useful for anxiety, but it combines well with SSRIs because it's got unique mechanisms of action that are esoteric. It blocks presynaptic serotonin and alpha adrenergic receptors, okay? But it ultimately increases both serotonin and norepinephrine, but not by reuptake inhibition. And so there's no redundancy when you combine it with SSRIs and other antidepressants. It also has less nausea and GI side effects because it actually has antiemetic properties. It blocks the serotonin 5-HT3 receptor, just like ondansetron. And it also helps to reverse anorgasmia in a lot of patients that are having trouble climaxing because they are on an SSRI and they have too much serotonin. And so this Remeron blocks the receptor that helps to reverse that in a lot of patients. So it's got all these benefits. If you've got a person that you're already treating for depression and anxiety, you give this at night and it can help with the nausea and it can help with the anorgasmia and it puts them to sleep and it's not habit forming. Sometimes people are a little groggy the next morning, but the big drawback is weight gain. And it's because you're blocking histamine type 1 receptors. That's where the sedation comes from, but also you're blocking serotonin 5-HT2C receptors, and that stimulates the appetite. So you probably get a synergistic effect because hands down, Remeron is the worst antidepressant when it comes to stimulating the appetite and rapid weight gain. The only medications I can think of that are worse are antipsychotics, Clozaril and Zyprexa, to name a couple, but those aren't antidepressants. As far as antidepressants go, it is absolutely the worst, and so that limits its use in a lot of patients. Sometimes I can use it for a little while, and then now some patients do okay. Some patients don't gain weight on it, but most do, and I have to stop it. It's very effective though, but like Trazodone, this use is off-label, so the sedation is considered a side effect, but it's a side effect that we often exploit because it is a very effective medication, even in patients who are not benzodiazepine naive, patients who come in and they're complaining of insomnia and it's a chronic complaint, they've been given a lot of medications and they've taken everything under the sky. You give them this most of the time, even addicts, even patients that come in who may have an agenda even. You give them this medication, it's available in an orally disintegrating tablet, an ODT preparation, and they come back 9 out of 10. They come back saying, yep, it worked, thumbs up, they like it. A few patients are a little groggy the first time they take it, but if you dose it right, that's minimal and they develop tolerance to it right away. But usually, though, it keeps working. Patients don't develop tolerance to the soporific effect the way that they do with benzodiazepines, because with benzos, you immediately start downregulating GABA receptors. You start downregulating the very receptors that you're targeting. And that's not the case with Remeron. But again, weight gain. Tricyclics are old school medications. They're the first generation antidepressants, also along with the MAOIs. So the MAOIs, the first antidepressant was an MAOI, and it was discovered serendipitously by accident. And then the tricyclics were developed, and then more MAOIs were developed. But so the first medication antidepressant was actually MAOI, a medication that was being used to treat tuberculosis, but the tricyclics are considered the first generation antidepressants, and they include medications like amitriptyline, protriptyline, or triptyline, the triptylines, as well as Doxepin, which is the only tricyclic agent that is actually approved by the FDA for insomnia. We use all of them, but we're using them off-label except for Doxepin. The tricyclic agents are actually SNRIs. They are serotonin norepinephrine reuptake inhibitors, like Effexor and Cymbalta, the second generation of SNRIs. There are numerous off-label applications for this class of medications, including neuropathic pain, migraine headache prophylaxis to prevent migraines. Imipramine is approved in children ages 6 and older for nocturnal enuresis, bedwetting, and that's exploiting the anticholinergic side effects of this medication. You could use any of these medications for enuresis in children as well as adults. Clomipramine is the gold standard for obsessive compulsive disorder because it's highly serotonergic. It's unique along with imipramine. Those two are very serotonergic, whereas most of the others are largely noradrenergic, so mostly norepinephrine, but two of them have significant serotonergic activity, and clomipramine has the most. So there's all these different applications, and so if you're already treating somebody, say for major depression or OCD, and they're having trouble sleeping, but the primary target symptoms that we're trying to treat are proving a little stubborn or refractory, or they're severe, or I anticipate that I'm going to need more medications, that monotherapy isn't going to do it, just from my experience and the presentation and the nature of the illness and the severity and all those other variables that I alluded to. If I know that we're going to need something more and they're having trouble sleeping, then instead of choosing a lorazepam or just a sleeping pill, I'm not going to give them a sleeping pill. I'm going to give them a second antidepressant, a second agent that is very sedating. It's going to double as a sleeping pill as well as an adjunct to really get their symptoms under control. But the tricyclics have a lot of side effects. That's why they're not first-line medications anymore, including what I referred to earlier, the blockade of muscarinic acetylcholine receptors, anticholinergic side effects like dry mouth. You also get dry mouth when you increase norepinephrine. Blurred vision, up-close vision, you can't accommodate. It causes cycloplegia, where it's difficult for the eye to constrict the way it's supposed to the pupil. You also can get constipation with anticholinergic side effects, and that can be very problematic in the elderly, many of whom already have a tendency toward that. And if you've got another medication that also has anticholinergic side effects or that also causes constipation, you can get a double or triple whammy situation. And you can get intestinal blockade. It can be very serious. In most cases, it's not serious, but it's there and it can be very significant. Urinary retention, it's another side effect because you need acetylcholine to relax the bladder. And so if you're blocking it there, it can be very, very difficult. And again, in the elderly, in the worst case scenario, a person would need to be catheterized. And that happens, but that's not common. You also get tachycardia when you block acetylcholine because you kind of numb the vagus nerve a little bit, and so it speeds up the heart rate. That's not usually something people complain about, but when you get into an anticholinergic crisis, which can be life-threatening, you can overheat and you have this rapid pulse, and you can get anticholinergic delirium, and it's dangerous. Doxepin is the tricyclic that's FDA approved for insomnia at very low doses, 3 milligrams or 6 milligrams, versus the 75 to 150 milligrams that you use when you're using Doxepin as an antidepressant. It's also unique in that it's available in a solution. There are others are available in a solution, so it's for children or adults that can't swallow pills, and you can mix it with juice. But also Doxepin comes in a topical, a patch, and it's very strong antihistamine. They're all antihistamines, all the tricyclics. That's how they make you sleepy. But Doxepin especially, and it's also indicated for conditions in which you have a lot of itching. The psychodermatoses, where you have sort of a combination of a psychiatric condition that part of it is that you're itching all the time, you're scratching all the time, but there's no diagnosis other than that. So just the stress, it's psychosomatic. The Doxepin, any tricyclic really should help because what you need is an antihistamine. Clonidine is a medication I don't use for sleep. It is approved by the FDA as an antihypertensive. It also comes in a patch and an oral preparation, and a long-acting preparation is FDA approved for ADHD in children ages 6 to 17 with an oral suspension that's also available for kids, and it's usually given at night because of its sedation. The fact that it lowers blood pressure is a problem because even if you're not hypotensive on it, if you stop it abruptly, you get rebound hypertension that can be very significant. Your blood pressure can bounce back really high when you stop taking it, so you have to wean off of it. It's used in PTSD to reduce nightmares, and so that's usually where I see it in psychiatry, in a person who's not taking it for their blood pressure or someone who's not taking it for ADD. Really, adults don't take it. It's approved for children. And what it does is it stimulates norepinephrine receptors, alpha 2A receptors. And that ultimately inhibits the release of norepinephrine, which relieves vasoconstriction, and that lowers peripheral vascular resistance and thus the blood pressure. Your arteries dilate a little bit. It also lowers the heart rate. That's how it treats hypertension. In attention deficit disorder, theoretically, the medication is acting on postsynaptic alpha-2 receptors in the prefrontal cortex. It's also used, another indication for clonidine, is to treat symptoms of opiate withdrawal. So if you're withdrawing from heroin, for example, and you're having the cold turkey, where you've got the goose flesh and you're trembling and you're sweating, you have these cold sweats because you're hot and cold, and diarrhea, and you're just miserable, cramping. The clonidine in reducing norepinephrine can help with the tremors and the sweating and the cramps. And so it's not methadone, it's not going to reverse the agony, but it can help some of those symptoms. That's where I see it being used as well a lot. It's probably useful in tic disorders. It's used off-label to treat Tourette's. Finally, I'm going to talk about Lyrica. Lyrica is pregabalin. It's a calcium channel blocker that's used to treat pain, neuropathic pain, and it's a whole lot more effective than gabapentin. I'm speaking from experience. I take Lyrica for peripheral neuropathy, and it is way more effective than gabapentin, but it's also incredibly sedating. And you do develop tolerance to the sedation, but it's a side effect, and so it's not approved for sleep. What it's approved for by the FDA is for diabetic peripheral neuropathy. It's also approved for fibromyalgia. It's approved for post-herpetic neuralgia, so maybe after you get shingles. But it's also used to treat other neuropathic pain, and it's an adjunct in certain seizure disorders, and it's used off-label to treat generalized anxiety disorder and other anxiety syndromes, including social anxiety. It's been tried in bipolar disorder, but it's probably not effective there. But I want to talk just briefly about using it as a sleep aid, because it is a controlled substance. It's Schedule 5, which is the lowest schedule. There are 5 schedules, so it's the least concerning schedule. It's considered to have the lowest abuse potential, but it is controlled. Pharmacies do monitor it, and they don't let you refill it early, and it's when they do fill it, it shows up in the National Registry, and patients do abuse it. But I don't see why, but I guess patients who like downers, but you do develop tolerance to the sedative effect. However, what I've noticed, taking it every day as I do, and not feeling sleepy with it because I've developed tolerance to that, and also because I'm taking Wellbutrin. I started Wellbutrin to increase norepinephrine, to keep me awake because of the Lyrica. I don't know if I weren't taking Wellbutrin whether I would have more sedation with Lyrica. It probably wouldn't be as sedating as it was originally, where I was falling asleep sitting up. And I literally fallen asleep sitting up. It was so sedating that I discontinued it because it was giving me that problem. And I switched to gabapentin, and the pain was so much worse. And then I switched back, and so Lyrica is better. It is better for pain, and that's been established. But what I've noticed is that even though I'm not particularly sleepy and I can lay on the couch and watch TV, and with the Wellbutrin on board, I'm not falling asleep. But when I go to sleep, whether I go to sleep on time or whether I've stayed up past my bedtime, and I'm pretty erratic, I'm gonna have to admit. I'm not very regimented with my sleep. I different times every night, which is terrible. But whenever I do put my head on that pillow, sleep latency, as far as I can tell, it's almost nothing. It's less than 2 minutes. I mean, I am out. And I'm not out like knocked out, but what I'm saying is I fall asleep. I never lay there thinking like I always have my whole life. And the only thing I'm taking is Lyrica. So I tried it in a patient recently, a patient who was on 3 milligrams of lorazepam, 3 or 3.5, I want to say. She was on a huge dose of lorazepam. She had tolerance, so it wasn't working. And she was laying there awake, and I added Lyrica, and We had to increase the dose once, but she started at 75, ended up on 150. And I told her to take it 2 hours before bedtime because it's a delayed sedation. And it worked. It worked. Adding Lyrica a couple of hours before bedtime to the medication she was already taking at bedtime. And for months and months and months, to date, she's doing well with that combination. So I urge clinicians out there to give that a try, because you do have to caution them, right? Because you're combining Lyrica and, say, a benzodiazepine, and so there can be a synergy whenever you combine sedating substances. You do have to be careful, but there's no absolute contraindication. And instead of just adding more milligrams of lorazepam in that instance, I added Lyrica and it worked. It was a home run. So I really appreciate not being sleepy, but then being able to go to sleep like that. I mean, I have no memory of laying there with my head on the pillow. The initial insomnia, just falling off to sleep, is much, much easier with this calcium channel blocker. It blocks calcium channels on the nerves and reduces their excitability. So that's kind of an overview in a nutshell, some of the different agents that we think about using, and maybe you can discuss more with your provider if one of these might be right for you. Thank you for listening. Comments are always welcome.